pledge to the flag.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Don's out of town, so we asked him to chair the meeting for him. So I will do so. There's no public here, so I guess we have no public comment. Approval of consent agenda. Everybody happy with the consent agenda items?
I would so move that the consent agenda items as listed be approved.
Moved and second, those in favor?
Aye.
Aye. Passes.
So, do you have the check signing done?
Do I have
Do we
one?
have the check signing calendar?
No, I don't have it.
You can't approve it if you guys don't have that.
Come on.
We changed it anyway.
Yeah, right. No, I don't have it. You got it.
I emailed it.
I know, but I waited for the meeting agenda.
Yeah, here,
Okay.
there's the dates.
I can do-
Tell me what you want.
I can do the 12th.
Jane on the 12th?
I can do the 5th, the 12th, the 19th. I can do any of those.
I can do the 12.
Gerald on the 12th, okay.
I can do the 5th.
I'll take the 19th. Is that?
Thank you very much, sorry.
Yeah, they're all Wednesday. Judy on the 19th. And you know what, I'm gonna put Dawn on the 22nd.
Teach him to miss the meeting.
Yeah.
Coffee for anyone? Chuck, you said you wanted coffee.
Yes, I'll get some.
Judy, would you like a bottle of water?
Please.
Okay.
So you want me to go through all that again with the approved check signing list now complete? Again?
Thanks for reminding us, Jen.
You're welcome, because I would have been like, who's coming to sign?
You've been calling.
Oh, just what we need. Thank you.
No problem.
I'll pass it down this way.
I know Gerald wants water. And also brought some
Oh,
snacks.
mix, yeah.
Trail mix, if anybody would like trail mix or snacks.
What is it, Charlie?
Trail mix packets.
He was the stewardess in the past life.
Napkin? Okay. Oh my goodness. Jane, can't eat all this package.
This is supposed to pass along.
I don't think this is our
Thank you, Larry.
Yeah, let's leave those cookies right here.
for water.
The cookies are on their way. Ladies, cookies are coming. Not to worry.
He's got something down.
There's a reason. All right. Grab your cookies.
And there's right here.
Okay, so June was a pretty good month. We had 331 total patients. Our average monthly patient count for the year was 334, so this was a pretty good month. What I note is that we're down 431 patients in the ED, which we kind of expect because we're trying to push people into going to more appropriate care settings and sort of a shift from surgical inpatient to outpatient. So overall an increase, but there you see a decline in outpatient. Ancillary visits were all very strong. Year over year, you see very significant increases in all of these departments, except for health clinic, which was down actually 363 patients year over year. I think that has a lot to do with some of the issues we had around providers being absent and leaving, and I really think that was a big part of it, and moving is disruptive and caused some problems. So at this point,
We are also, we've disrupted how the physicians practice. So because they had in the past 2 rooms that they could work out of, now they have 1.
For now.
So for now, when we finish our construction, that will change for now. But it cuts down on their efficiency.
But also, I would say that Dr. Foster and our new FMP Kathy seem to be pretty content with working at Lake District. You know, they're expressing their needs and wants, and we're helping them get, hopefully, I think they're happy, and they certainly have been productive. So I can see that only getting better. It's kind of exciting. Okay, our gross monthly charges, patient charges, our charges for the month were 3.24 million. So a little bit less than they were in May, but still a very strong month. Our monthly average is 2.9, so again, June was a good month. And when you look at, this slow, steady increase year over year of gross charges, that's a good trend. Our collections on AR were at 1.54 million for the month, which is about 350 less than our average of 1.9 million. So it was also probably a lot lower than you'd expect given our good revenue the last several months. RICAN had a little bit of a bump in there when they turned it on, didn't work exactly right, and kind of backed up our Medicare billing for a few weeks, but it's all cleared up now, and Lisa will tell you more about RICAN in a minute. So that was kind of another reason why we're having a little cash flow out. Our days in AR is here, it is at 78, so it's up 5 days from May. Again, the RICAN install, I think is going well, and do you want to talk about that for a minute?
Sure, we've completed all of the important pieces for the implementation, which is really great. We did have a bit of a slowdown with Medicare that lasted longer than I would have liked. It was stuck in testing, so it got to the point where I told them, you need to switch it back so we can bill out of evident because we can't let these claims sit here any longer. So they flipped the switch, and then of course, Medicare released our claims from testing, so we went back to RICAN. So we had a little over 400 claims that were stuck in Medicare. It usually takes them about 14 days to pay once they're submitted. So I expect to see a bunch of money coming in the next week and a half or so. So I'm excited about that. The implementation has gone fairly well. Right now we're just working the bugs out. So they have a lot of set edits and things like that. And so we're going in and customizing the edits to be the way we need them to be. So it's going pretty well. The only piece we still have left to implement is the patient liability estimator, but that won't affect our revenue or our days. That's basically so that if you call in and say, how much will it cost for me to X, we can give you a good estimate for that. So that's the only piece that we have left. So I'm pretty excited about that.
Do they have a time set for that implementation?
Not yet. I'm not really pushing for it to happen quickly because a lot of it has to do with loading our existing contracts into their system. But a bigger thing that they do, which I really like, is they use our historical data. So once they've processed EOBs, they save that data. So if you call in and you say, I have this insurance, how much will this cost me? They'll actually look at accumulated data from previous procedures that we've done of that specific thing at this specific hospital, and they can give us a better answer. So I think once they build that database, it's going to be a really good tool for us.
So then our days cash on hand ended here at 84, which is below the 90 that we need to maintain for the bank, which is this black line right here. That 6 days short equates to about very close to $500,000. So part of it was our, we've been spending a lot of money on expansion and growth. Part of it was our delay in cash in the collections that we might have gotten from Medicare. So another factor I think that's kind of biting us right now is that the changing payment methodologies that we're trying to learn how to deal with. Right after closing, we got a check for $160,000 from Gobi, which was the result of a risk pool. So when you know that you're going to get some money, but you really don't know how much you're going to get. Right now, we're also waiting for money from EOCCO, which we think NOM is estimating should be in excess of $200,000. But really, there's no way to book it because you have no idea what it's gonna be, but it certainly has an impact on our revenue and our profit, and it's certainly the delay, you know, pushing out receiving compensation for the work we did is just making this whole thing challenging. And it's been a learning curve, I think, for us and all the rest of the hospitals dealing with this.
But Cheryl, once you receive that, you can't rebook, you can't book that back into the prior fiscal
I
year.
can't, well, I can't get the cash, I mean, so, yeah, you cannot. Now, I did actually, you can, I went back because it was so close, and I opened the books and I put that 160 in last year. So I'm gonna send you out new financial statements, and the one I'm showing you tonight is $160,000 better than the one I sent you last week, because I just think that's the right thing to do. I do think, I'm gonna look into what did we do last year. I know at least we need to be consistent. I'll ask our auditors what they think about it. Of course, you have all those audit adjustments that you know, they look at, they contemplate. So I think that'll be a good conversation to have with them about how should we treat that. Because I can't accrue it. I have no idea. It's a risk-sharing pool, so not only, you know, some of the money is based on quality measures, so we're more sure about that piece of the money that we're gonna get, but the rest of it's kind of dependent on how did we all do together. So,
The challenge from the EOCCO standpoint, so that's the Medicaid population, Medicaid contract. Keep in mind that we have two sets of risk pools. The risk pool for the hospital, the risk pool for the clinic, okay? For the physician component of practice. And then there is the incentive dollars that go based on if we meet the metrics. Why it's difficult to estimate is the CCO can very accurately calculate how well it's doing. Eastern Oregon CCO, and it's been doing pretty well. But the amount of money that's in that risk pool, that it impacts the hospital, the physician group, and then, of course, the incentive dollars, has gone from $500,000 when we started in 2013, roughly, to $11 million now. So it's a significant amount of money, and that can tell whether or not the CCO itself makes all this money.
How many hospitals, Charlie, are involved?
There are 12 hospitals in Eastern Oregon CCO. 5 are the small hospitals like us, which are us, Burns, John Day, Hepner, and Enterprise. So we're all cost-based hospitals. The other hospitals are a little bit bigger, and they are not exactly cost-based. They're large enough that for the Medicaid business, they're still critical access hospitals. But for the critical access hospitals, Medicaid or the state determined that they could get fee-for-service for Medicaid. We still get cost-based service. And then once we finish all this reimbursement, we still go to the cost report, and that adjusts our rates. So that's why with all these moving parts, it's really hard to estimate. And the state doesn't give out the information. Even though the year is supposed to end the end of the calendar year, it really ends about May. That's when the state comes, and the state doesn't, for the 2018 period right now, it doesn't even come out with the metrics that we're held responsible for until June. And we don't get, because there's the 90-day lag from the claims, we can prove we've met the metrics or not until about May or early part June. So this month, when we meet a CCO board meetings, we'll be deciding how much money is distributed for this. And that distribution may not come out until September. So it's really a difficult thing to estimate.
Is there, in your general accounting rules, is there any rules that you can't just treat that as a cash basis?
you probably, but then it'll have to be in fiscal 19. Yeah, I mean, I think that's what we're gonna have to do, but I kind of wanted to, I don't honestly remember what we did last year. If the auditors, because your cost report adjustment does go back into the appropriate year. they set it up as a receivable as part of the adjusting, the final adjustments that they do. Once they do the cost report to figure out how much you're gonna get or give, then they book it into that year. So I don't.
Does risk money affect the Medicare cost report?
No, no. So I imagine what they'll advise us to do is they'll look around and see what everyone else is doing, because that's usually what, the majority, whatever the majority of people choose to do. If all the bigger hospitals are doing it, then they'll tell us to do it. So I'm not sure. This is really on the second year we've had to deal with it, and it's gotten bigger, so,
So Cheryl, will you back up a screen, please?
yeah.
Remind me again, how long can we go under that 90-day limit that we have for
We
cash
look
on
at
hand?
it on a quarterly basis.
It's a quarterly
So they're
basis.
not looking at it month to month. So
Right.
they looked at it for March and they looked at it for June, and it's been under for both. So I called Leanne and I said, well, yeah, but we have these circumstances, and we'd like you to maybe consider whether or not you could, give us another quarter. So I'm hoping that that money will really come in, and then my story is more plausible because, hey, look, it showed up. And then hopefully we can go from there.
So what's the penalty for us if we go another quarter and we're underneath those 90 days?
It'll increase the interest rate on the loan outstanding for a period of time, for 1 year. And then we'll start again.
For 1 year. They haven't done that yet, though.
No, they haven't done that yet, so I'm trying to get them to not do that. Okay, so going on, the profit and loss for the month of June. Our revenue was good, the net revenue is 2.7 million, which was 243,000 over budget, so that's crazy good. This has quite a bit to do with the fact that I did get 2 checks from Gobi, one that was for 70 and one that was for 160, that was for these quality or risk sharing measures. So that's how come we got, extra revenue up there.
Just so that we're clear, Gobi is for the mental health group, so the wellness center. So I actually left that out as a risk component. So we're at risk for the hospital, risk for the clinics, risk for the quality metrics, and then risk for the wellness center, mental health service. So there's a lot of things that are moving in.
Yeah. Okay, so total expenses were under budget by 156,000. We had a net gain, a total gain of 190,000. We had a net gain of 374,000, which is 363,000 ahead of budget. Year to date, we are under budget $2.3 million, but we are also under budget in expenses by $2.8 million. And again, remembering that non-operating was a big contributor this year, so that's good. And year to date, we're at 730, but that's before lots of adjustments that we're going to make for the cost report, for the EOC steel money, for debts due from Lake Gardens and Goose Lake Medical, and for rebuilding of Goose Lake AR. So I'm going to try to do an estimate on what I think that might be, and I'll send you guys a report on my estimate is on that. Okay, balance sheet really didn't change much again. The AR went up because the days in AR went up, and the debt went up, or the assets and the debt went up. The assets went up because we paid Detroit. The debt went up because we borrowed on the bond. So nothing unusual on the balance sheet. It's been kind of boring. So that's all for Lake Health District. And then we would talk about, Lisa's going to talk about the financial assistance policy.
So I think you all received a copy of the change. All I did was I updated the graph at the bottom to be at the 2018 poverty levels because it was still at 2017. And in the top, I changed Lake District Hospital to Lake Health District because we use that same application across the board. So I thought it was a better encompassing umbrella. That's
Okay.
We have a motion to approve that.
I'll move that we approve.
Financials.
I'll second. Did you second it, Joe?
No.
I'll second that.
Okay, it's been moved and seconded to approve the policy 9-95-205 financial assistance policy. Those in favor?
Aye.
Aye. It's approved. Who's like medical services?
Okay. Patient counts, I had to do a little bit of estimating because we're not actually tracking the ALF counts yet, so we had, Larry, was the ALF open?
No, this isn't Goose Lake.
Yeah.
Oh, Lakeview Gardens, I meant Lakeview Gardens, I'm sorry. Goose Lake, Lakeview Gardens is part of Goose Lake. That's why we just kind
Oh,
of
okay.
call it that on the thing.
Gotcha.
But this is Lakeview Gardens, sorry. Larry, when did the ALF open?
June 4th.
June 4th. So this is very nearly our first whole month in having the ALF involved. And right now, I think we have 18 in long-term care and 19 now in long-term care and 5 in ALF. So anyway, I will get this number firm, but that would be based on a full month of the post-market.
Larry, have you made your presentation in Alturas?
Yes, I did. I
How did
presented.
that go?
It went really well. They had a pretty good showing. And then I also stopped at the Chamber of Commerce and the Senior Center to disperse some pamphlets down there as well. And one of the Rotarians down there is involved in some board member stuff. I can't remember exactly what, in Cedarville. And she took a handful of pamphlets and said she was going to pass them out there because I was unable to schedule a meeting with them on Tuesday. And I also spoke at Lions yesterday, the presentation.
So Larry, we have 5 in assisted living because that is all we have right now? I mean, we are able to take more,
Yes,
but
we're,
we don't have anyone ready to enroll.
I have, over the last couple of weeks, I've had a lot of interest and people inquiring about it and saying, you know, I'll get back to you at the end of August, or, you know, I have to try and convince my family members and loved ones to move in. So that's kind of the biggest obstacle right now. But I received 2 calls from last month that were saying that they're going to wait a little bit, that are starting to send me medical records and medication lists of those family members to start moving them in. So I'm hoping to have hopefully a couple more move in this month. And I'm hoping with my presentations at Rotary here and in Alturas and the Lions Club, I hope I get a lot more inquiries.
Oh, you guys weren't, he presented at Rotary last week,
Yes.
last Wednesday. So,
Yeah.
and it went really well. It was a good presentation, except the person who was doing the slides.
How's the census in the long-term care in Cedarville and Alturas?
I didn't really get into census down there. I don't know about Cedarville, but Alturas, I didn't ask.
I do know that because of the fires, several of the hospitals have been prepared to accept patients if they get transferred because of the worry.
In visiting with the long-term care patients, to me, I think what is going to ultimately make the difference, like it does so often, is the results of those people that are in there and how well it's working for them. When that word gets back into the community, I think that that's going to really help you with your census, Larry.
I'm hoping so. Because a lot of people on our admissions list were kind of hesitant to move in right away
Yeah.
because of some of the bumps in the road when we moved into the long-term care.
Yeah, and I had extended conversations with 2 of the residents, and they were both very pleased with how it was working out individually for them and how it was fine-tuned for their care, for their needs. I think there's always apprehension when you go into that type of a facility, but with these 2, it was the best thing that they could have hoped for.
And are
And their
they
families.
long-term care or ALF? Long-term care?
This was in the assisted living.
Oh, in assisted
Yeah.
living.
Yeah, we have a really great team there that really pay attention to the cares and make sure everyone is receiving everything that they require. And I can't speak highly enough of the people that we hired to work there.
Can your assisted living patients have a car?
Yes, they can.
So they can come and go at will?
Yes. All we ask is that they sign in and out, so then we know when people are leaving, where they're going.
Sure. Estimated time home or something like that?
Kinda like a
Does that even
teenager.
matter?
Well, also in the event of an emergency, so if
Sure.
there's a fire, you have to evacuate, you need to make sure you've gotten everybody.
And for instance, we have a resident who will go down to Ace in his electric wheelchair. And with the smoke and the heat and all that, it's kind of worrisome for us. So we ask him to take his cell phone, keep it on. We make sure the volume is all the way up and fully charged, along with his wheelchair, to make sure he can make it to and from safely.
Didn't you want to do your teenage kids?
I think Mary's got me on that list already.
Monthly revenue was down just a touch at 177 because charges wasn't out. Our net revenue was 177. Our expenses were 309. We lost 132 for the month. We lost $1 million for the year. Exactly what we thought we were going to do. Wages have been tough on us, and contract labor has been tough on us, so. But
We got enough labor for us now.
I think we do. I don't know. Enough labor, enough workers?
Or be fully staffed.
Long-term care.
Oh,
yeah.
yes, we're,
Alternative and,
The biggest problem, of course, is the contract labor.
yeah, so you're still at the same level with contract labor.
Travelers.
yeah.
Yeah.
Well, we just lost 2 CNAs to the clinic this last week, and one's out on federal leave, so.
Keep dreaming.
Big middle class. Right,
It's a national problem.
it is, yes. Goose Lake Medical had a positive month. They had revenue of $62,000. They had a net profit of $4,500.
Can we clap now?
You got rid of that screen really fast.
Say that again, slowly.
Let's look at that a little bit.
Yeah.
Yeah. So,
Yeah, sorry.
okay.
Couple things to think about. So, what I said I would do at the last board meeting is I'd go down to Sacramento. I enlisted the support of Representative Dolly, who is our Dave. Is that, am I saying it right? Is it Dolly or Dave? I think so. So I got his staff members to support. We got help from the California Hospital Association. And with Cheryl and Mike Perseverance. I don't know.
Constant harassment.
We actually saw a movement, and our application went from Sacramento to Chico. So it was approved from the Sacramento level, it's at the Chico level.
We have it in writing.
We have it, and it is, they are reviewing it in Chico. One of the things that California Hospital Association said is, I don't know if I told you this, they have made some legislative proposals to require that if the state doesn't approve an application, within a certain time period, it's automatically approved, because they have documented cases where the state has not opened up the mail for a year.
Not open the mail?
For a year.
What are they doing?
Just stack it up.
They hired 40 additional people to try and deal with this. It's their central administrative unit. So getting it out of that is a big step forward. So we're just waiting for and the email I got this evening, well, late afternoon, from the Chico office is they're just verifying all the information to have the change of ownership get processed. So we haven't got it finished yet, but it is significantly further along than we've had all the promises. We had it.
How long has it been?
Year and a half, February of 2017.
Is there anything after
thing and then it'll be burned.
I know, that's what I'm.
And once we get the candy, I think we've got it made.
Chico is the regional office for determining this kind of information. We had worked with the Chico office about 3-4 years ago to get approval for our Bruce Lake Clinic to do home visits. You may recall they don't have in the Modoc County any home health agency. And rural health clinics can, where there isn't a home health or hospice agency, we can provide home services and get paid. So they were inpatient. We started doing that, but there were some problems in actually finding nurses that were capable of doing home visits with all the documentation. So we held back with it. But we do have the license. So they're familiar with us. They know what services we deliver, especially the CCO in that area is called PHP, or Partnership Health Plan. Similar kind of arrangement. We've been a contractor with them. So I believe we'll be moving forward much faster.
Good.
Medical supply company, they made $6,400 this month, they made $52,000 on the year, so not bad, because they've been through a lot of change and transition, and so they're hanging in there.
All right. Any questions? We'll move on. Medical staff privileging. This Charlie, you're in charge. Dr. Graham's not here.
Dr. Graham was going to be here, but things changed. So in their stead, at the last medical staff meeting, I think we sent out to you the list of all of the
They're changing
renewals.
radiology, seemed like 8 or 9 of them had to do.
So the vast majority of those, this is just the renewals, so they're not changing. They have 17 or 18 full-time physicians in Bend that are in this group. And then they have their other contracted group. So this is the principal core group. And Dr. Stevens is the ophthalmologist that works with Dr. Fay in Climate Falls, and comes over here. The new doctor, Dr. Rexy. How do I say it?
Barecki.
Barecki.
He's a new Cora grad, so.
So, the medical staff recommends that you approve these renewals and the new application.
So moved.
Second.
Moved and seconded to approve the medical staff privileging. Those in favor?
Aye.
Aye.
Thank you.
And it's approved. Thank you. Mallory, community education.
I asked Mallory to come and talk, to introduce herself and talk a little bit about what she's doing. She's just come on as our community education person. So Mallory.
So I'm actually working on quite a few things at the moment, just trying to kind of get things just rolling. Some of the projects I have going on, I'm working on ways to revamp our website to make it more functional, user-friendly, up-to-date brochures with accurate services, social media presence, community education and awareness, advertising, everything kind of that falls under that category.
Are you still involved with the newspaper too?
I'm sending them the hospital's ads.
She's ours now, Chuck.
So Mallory's our new web lady, our new internet, our new, good deal,
The website has been a fun one to try to tackle.
I bet.
Mallory
been-
is trained as a graphic artist.
Yes.
Pardon me?
She is trained as a graphic artist.
Oh, that's cool.
And so I've been working with Fast Health, our current company, as well as some other potential companies, depending on how Fast Health does with the changes that we're looking for, to try to get our website, where it needs to be.
So she's helping you out a lot, Jen.
Yes, and she took all of that, so I can devote to, because now we have credentialing in-house, so that was a really big component to take on. Thank you, Morgan. And so, yeah, she took all of that, which, I mean, I didn't have the time to devote to everything she's doing. So I think it's gonna make some big changes.
We're happy to have Mallory.
Yes, welcome aboard.
Yes,
Glad you're here.
thank you, Mallory. Resolution on the workplace violence, Charlie.
So one of the things that we learned in our, certainly our, the forums with the Hospital Association is there's becoming a bigger and bigger push to deal with safety. It's happening not just locally, but on a national basis. And we think about workplace in the term of workplace violence. That is a catch-all that really is becoming more and more significant. The Oregon Hospital Association has just recently created an arrangement with the Washington Hospital Association, because Washington has been a national leader in dealing with safety. And so we formed an organization to try and really raise the bar on quality and safety. In fact, the Hospital Association for the state of Washington, Oregon, and Alaska are applying to Medicare for some special funding to really bolster our tracking and monitoring. Oftentimes we think of safety as, oh, somebody comes in to the emergency room and confused and gang-related, and therefore people would be at risk. What we fail to remember is the people that are impacted by safety, by patients, the most are our direct caregivers, our aides and CNAs. They get kicked, and bitten, and punched by people that are confused, or when they come in, or their medication's not working right. They're getting hurt a lot. We're working to try and address that, not only on a statewide basis, but now the state is requesting that, or the association is requesting that all the hospitals take a very firm stand on reducing any kind of workplace violence. So I'm asking that you consider doing this. It's also important because our state legislature is talking about putting in mandated requirements that all hospitals do workplace safety. So this is a way to help get in front of that and say all of the hospitals in the state are actively looking to address safety issues. I recommend that we adopt this, and we'll be doing more and more with our staff. When we talked about safety at what other hospitals are doing, what we're doing, I reminded my peers how we put in a lot of lifts. We spent a lot of money on them, so we've reduced the number of not only patient falls because of that, but employee harm. We don't have the back injuries like we had in the past, which is an enormous benefit to everyone. So that's why I recommend that you approve this.
Make a motion, we approve resolution number 2018-5 on workplace violence prevention. I'll second that.
Moved and seconded to approve the resolution. Those in favor?
Aye.
Aye.
Thank you.
Passes. Thank you. Charlie, your favorite thing, employee of the month.
You know, we have some fabulous people, and it is always uplifting to think about how much people care about our community. We recently have had some changes in staff, and that anytime people come or go, it puts an added burden on those that are still here. And sometimes it's a great thing that people get new jobs and they leave our community. Sometimes it's hard for us. But rather than an individual, this month, the employee of the month is the entire housekeeping or environmental services department. When our last manager left to take a great job, all of our, and we're now calling them environmental services, not housekeeping, the entire EVS staff worked like the Dickens. And they really did a great job. And Quentin, our now supply chain manager, who was, that used to be purchasing, now we're changing our terms. He also took on the responsibility of environmental services. And he managed with all of the crew, to hold things together, did a great job. So it's environmental services team. Great job.
Thank you. CEO report.
So, many changes are going on. One of the first things that's exciting is we brought on Susan Snell as our new environmental services manager. She started this week, I believe it is, Monday. So we're very excited to have her here. She came from Reading, and I'm sure she's quite pleased to not be here for all the added smoke was. Next, we are able to officially appoint Nam Davi as our clinics director. It took longer than we expected, but we had to get her H-1B permit to work in the country all sorted out. We got that resolved. She is able to keep working in the country, and so she started as our clinics director as of August 1st, yesterday. So that's really exciting for us. July 1 began our first next step in dealing with public health. So public health employees are now part of the district. By all indications that the transition isn't going well. They actually are beginning to have air conditioning in their building, so that's a really positive thing. Those of you that know about the latest building, they've suffered every summer from lack of air conditioning, and times they've actually had to close the department down because it's too hot to work in. So that is moving ahead, and our IT processes organized so that they switch from the county to the health district. We get them to where they actually have voicemail. Not everybody has voicemail in the department, so it's those kind of things that are making really positive things. We're going to be working on the billing, sorting that out. They have not had electronic record. They've had billing separately and using the attendant system. So there's a lot of changes that are going on, and all the employees are saying that they're very, very pleased about this transition. But we did finally get our long-term care survey. It was 6 to 8 months late, but they did show up, and they showed up on force. And I think we had 6, or was it? We had 5 or 6?
6.
So quite a number of people came. We have not received their final report. They gave us some reports of things that we have to work on, but we have not gotten the final report, so we can't respond yet. We are working on a response for the mental health survey, which we have to respond to. And most of that were things that most of this deals with issues related to charting documentation. With the long-term care survey came the fire marshal survey. So we had that, and they found some things that we needed to address, and we're taking care of that on our brand new building. So, and they promised, the fire marshal said it's very possible you'll get the federal inspection shortly for the fire marshal's standpoint. We haven't had that happen yet, but you never know. And he said that fire marshal might come, the federal officially, it's done by the Navy, and they may show up in a Navy uniform. We'll see. Construction update. The long-term care and assisted living. You'd think I'd be finished talking about construction since it was a year ago that we moved in. Well, last month you approved putting in panels around the sides to protect the walls. We originally tried not to put those panels in because in the view of the greenhouse project, that made it too institutional. Well, it makes it look much cleaner. And so all the rooms have had that, all the patient rooms have had 2 sides of the walls protected, and that really makes it look much better. The floor drains. You may recall we talked about how we were having some trouble with the drains not draining correctly. That's still not finished, but they're working on it. Next week, we have our final survey with the architects and the contractors to review everything. So that's the end of the 1-year warranty period, so we'll be going over that. Mental health, the formerly law office of Bogarts and Headland, the plans that you approved to do, they're painting today and should have the work done, was to be done by the end of July. It's now 27th of August. They'll be able to move in. There's a delay in getting the doors. So, pardon me? August 27th is when they'll be able to move in. It's the soonest that, and that was directly from Rob Gordon this morning. Clinic remodeling, they're ahead of schedule. So it is looking like we'll be able to move in November, not in December, end of December. They haven't got firm dates yet, but things are progressing well. So we're even working on schedules if we could maybe move specialty clinic into the specialty clinic area sooner than November. So that's all progress. The operating room remodeler, we're still fiddling with a couple of things, and our goal is with not having Dr. Skrinsky here, we'll be able to put in the sterilizer and make the slight changes that we have to get that done before she gets here. One of the concerns we had was scheduling around her time of doing surgery, because you don't want to have any dust or anything that can contaminate the operating suite. So they understand the timeline, and their plans have been approved, but they're still making some slight adjustments. We recently had CPSI for 2 reasons. As you know, we are considering, I was hoping to have by the end of summer, a proposal to you on what to do with our electronic health record. We've been using CPSI since 2011, and we now have CPSI in eClinical in the clinics, and we have T-System in the emergency room. We have point-click care and long-term care. We have so a lot of disparate systems. So we're trying to figure out, does it make sense to stay with CPSI, put CPSI in the clinic, to have CPSI in the emergency room, that sort of thing. Secondly, is consider CERN, large company, or Epic. If you look at Epic, you look at multiple versions of Epic, because we couldn't get it individually or as a hospital, but Sky Lakes, as an example, could not get Epic on its own. It partnered with Asante, a 3-hospital system. So there's 4 hospitals using the Epic system at Asante. The options that we would look at from that standpoint would be possibly St. Charles, because they now have Epic, Legacy, OHSU, Asante. Asante told us no, that they were at capacity, they weren't interested. So we're still working with the other possible partners. St. Charles has indicated a willingness, and we're scheduled to have them come out and make a presentation. If we have a reasonable idea what the cost will be from both Cerner and Epic St. Charles. We're not ready to make a recommendation, but neither one, if we make the recommendation, would happen for a year. There's a lot of work that goes into it. So CPSI, in its interest to not lose us as a client, is come out to make presentations, and they've also come out and done what they call a SWOT analysis. How well are we using their software, and what could we do to do better using their software, therefore like it better? So they came out and did that last week, I believe it was. And, well, I haven't gotten their final report. Made a lot of suggestions. A lot of departments said it was great. Learned things that they're doing. No matter what decision we make, for the next year, we'll be using CPSI and eClinical. So even if we were to say, oh no, we're gonna stay with them, there'll be times of transition, whether we make the recommendation to change your name, God bless you, we will still. So that's sort of the process that we're going. I don't believe I think I was over optimistic to say we could have an answer by the end of the summer. Recommendation to you. St. Charles held back because they just went live with their Epic system in March, and they're still working the kinks out. Burns went live with them, and by all reports that I get, transition went well, and that they're pleased with that transition. That doesn't mean it's perfect for us. We still have lots to learn. But St. Charles held back with even coming out to make a presentation until they were prepared to say we are willing to do this in a year. So that's kind of the process. So understand about that. One of the things that we've done, Larry really worked hard to get, is for transportation for all of the Gardens patients, whether they're in assisted living or long-term care. He's worked out an arrangement with the senior center to provide that non-emergent pickup and delivery service. That went into effect in June, correct? July. So that's now in force, and that's really working well to partner with the senior center. So we're glad. We may still be able to work out other arrangements, but for now, it's a great, and it helps everyone.
Do we have to pay for that, Charlie?
Yes. And part of it is for, the senior center provides service to seniors when they make arrangements with the senior center. But if we ask them, then we would pay for those kinds of services. If that, and that includes if someone can go back to Lakeview Gardens or assisted living from the emergency room. So if the emergency, if an ambulance comes and picks them up, how do we get them back? And that was one of the processes that we wanted to make sure. Also, as part of our assisted living, we want people to be able to go on outings, go to different senior centers, go to shopping events, and so making arrangements for that. That was part of why it makes sense for us to pay and support senior center in that business. We are finalizing arrangements with Drs. Chang and Dr. Brackett. Chang looks like it'll be in October. He's the general surgeon. You may recall we brought him in with, he has been working out of Burns, and they have some change in staffing there. So he was looking for another place. He and Dr. Bradbury worked together when they met here to talk about how this would work together. And so it's looking like it'll be in October. Dr. Brackett, we're still working on getting that finalized. Cheryl talked about Kathy Thompson, the PA that came to us from Christmas Valley. That's going well. We also have a temporary nurse practitioner, Brickman Shunya, who is a psychiatric nurse practitioner. He's been here for now about a month, 2 weeks on, 2 weeks off. By all indications, it looks like that's going to work out for him and for us, so we're finalizing an agreement to have him here for a year and a half. Now, one of the things we have to think about with that is we've had a psychiatric nurse practitioner supporting our mental health services through the Wellness Center, working out of Peace Health in Portland forever. But he's been overwhelmed and has tried different ways of getting people to help. What the psychiatric nurse practitioner predominantly does is help the clients with their medication management. So bringing Rigpa here was an opportunity to see if we could support. We had enough need for the psychiatrist that I talked to from Gobi, who works with other communities like this, said if you have 400 active clients in your wellness center, that's easily appropriate for a psychiatric nurse practitioner full-time. I said, well, we have never had that before. Her response was, yes, that's been dumped on family docs. They had to manage that. And this helps them by having somebody else manage some of that medication for them. It frees them up to do other things. So this is a really positive thing for us. So we're pleased about that. A couple upcoming things that are going on. The triathlon. It's going to be August 12th. Got the wrong months. So short bit. So you'll see a lot of kids running around. We're excited about that. And that's good for our community. And we also have on August 8th an open house at the Wellness Center for partnering with the veterans for suicide prevention. Veterans, unfortunately, are a high percentage are victims of suicide. And so this is an opportunity for us to talk more about our services and to support that process. I'd like you to note on your calendar the date October 22nd. It's a Monday. A national leading expert on board training, board functions is going to be coming to Burns. Burns Harney District Hospital is going to be supporting Jamie Orlikoff for a day-long presentation. It's a Monday. And they have graciously invited you to all participate. If you're available, we'll have a vehicle to take everyone up. And I think it'll be a really good session. What makes it reasonably cost-effective to have him of such a nature is he recently became a board member of the St. Charles Health System. So he's available when he comes out for those board meetings. He's based out of Chicago. Jane, you may recall, he's given several talks. He's well renowned, and this is a great opportunity. So I'm sure that you mark that as a possibility to attend. Other than that, I don't have anything else to say. Do you have any questions or comments from any of us?
The only comment I had, I noticed that the building now is all wrapped over the clinic building. It's all wrapped. When is siding going to go on that?
So what they wanted to do was first get the roofing taken care of. Now they're getting that siding or the wrapping done. They'll start putting they put in the new windows. They've then been delayed because there's a problem with the windows. Something with the manufacturer. So the windows on the west walls that are getting heated up are buckling. And so today we had the manufacturer here, and we're going to require them to replace all of the replaced windows. They're all highly, I don't think it's 3-pane, but they're very special windows. They're real good windows. So they're going to replace that. So that's been part of the delay. They didn't want to put the siding up, have to take the window. That would make it harder to put the windows in. And what they're going to do is they'll change those windows all the way around the building, and they will be changing out the windows for Dr. Graham's office so that they will all match, have all the energy efficient windows as that siding creates all the way around. So
That'll all get done before winter gets here?
Oh, yes.
Is that coming soon? Because I'm ready.
It's going to look really nice.
At least.
Any other questions? If not, we will adjourn the regular session. We'll take a 10-minute recess and return for executive session under ORS 192.660. Into ACHI. And we'll keep Charlie and Dave, anybody else, Charlie, and the board. Thank you for coming.
Should go get a district government presentation.